everybody. Thank you for this opportunity. And with the permission of the IOA dignitaries and other faculty members, I think we will press on. And I'm going to introduce you to shoulder examination. I must say that it's a complex topic. It's not, it's there's a lot of apprehension amongst our students and other students whenever I'm taking exams that they are absolutely fearful about the shoulder. So my main intention is to dumb down the shoulder examination. So I'm going to make it very easy. The entire presentation is inclined towards the PG student. It is not towards the consultant, but you can happily take few points from this. I know this is one of our most watched presentation. So for those who have come back again to listen to this, I have introduced a few new cases, and it's surprising how you come up with new tests every time. But there are hundreds of tests, and next 45 minutes that I've been given, I'm going to give you only what is required and what is necessary. So let's press on and move on. Now, the first thing is the reflex action that everything is not frozen shoulder. In its truest sense, a true frozen shoulder is extremely rare. And so don't make a job of calling every shoulder that comes from the OPD as a frozen shoulder. So I'm going to give you a plethora of different diagnoses and the most common one. The best thing about the shoulder joint is as the patient walks into the examination room, your examiner can look at the patient, and by age, you can understand what condition is likely to be. It's one of the few joints where conditions are sharply demarcated by age. So you have a young patient here is likely to be a traumatic instability or a traumatic instability. In the middle ages, you've got incomplete cuff, partial cuff, subacromial impingements. Elderly patients, late elderly patients, you have frozen shoulder beyond 50s, and then beyond 60s, you're dealing with degenerative joint disease and full thickness cuff tear. So what I'm trying to tell you here is it's extremely rare, and it's a black swan event to see a full thickness rotator cuff tear in a young patient. And at the same time, it is again unusual, not impossible, but unusual to see a recurrent dislocation in a 70-year-old gentleman. I'm going to start with a history presentation. I have dozens of these, but this is a 26-year-old young man. He's a short putter police recruit. And very clearly on history, he's giving me his diagnosis. He's showing me his pain. And I wish I could translate his voice to you. And he's telling me in supination and pronation, his pain is aggravated on supination. And on repetitive asking, he tells me that his pain is right over there on the AC joint. And typically it lasts only in that area. And in addition, if you watch the video below, you can see that he has a GERD deficit, but more importantly, his cuff looks very strong. His supra-infra are quite strong, and that's very unusual. And you can see his hornblower is also very strong. You must understand he's a professional short putter. And when it comes to subscap, this is my favorite test for subscap, is quite weak for somebody who's 26, and look at where. So when the test is positive and painful, ask him where the pain is, he'll point to the lesion automatically. So point I'm trying to make here is this is a biceps lesion with a partial subscap tear. And I don't need to do an extensive examination. All I need to do is just ask him on history, and on history itself, he's giving me his diagnosis. And there are similar capsules related to supraspinatus, related to infraspinatus, relating to neuropathy, which you can pick up precious information just from the history if you learn to listen to the patient. So to me, I think history is very critical. I'm very uncomfortable in doing an examination without history. On history, you must ask for the age, occupation details, hand dominance, and that's true for every upper limb condition. But typically, most shoulder patients come in a chronic manner with a 3 months, 6 months, 1 year history. If it's an acute event, then you must know what it is. It is completely from your usual conditions that present in a chronic manner. Typically, rotator cuff affections have a lot of night pain. So that kind of segregates your cervical spine disorders from the shoulder disorders. When patients say that they have pain on both sides, lateral sleeping, he's pointing out and yelling that I have an AC joint arthritis. It is our job to translate English into English. But if you're taking a young patient with a labrum tear, he may not have pain at all. And he may, only complaint he may have is inability to throw. So Typical cuff tear patient would be usually 60 plus, typically teacher, painter, and he'll have night pain, lateral sleeping pain. But the point I'm trying to tell you here is they have palm sign. They have deltoid pain. The reason for that is different. We'll go into that later. But don't miss a history of fall. So sometimes they'll tell you fall 3 months before and the pain started a month later. Coming to the scapula, probably by far the most neglected part of shoulders. And that is why in your exams, you must always strip the patient waist above and look at him from behind. That's something the students miss all the time, and they have missed the diagnosis because simple scapular winging, long thoracic winging, long thoracic palsy presents as an impingement. And unless you look from behind, you cannot diagnose this. But these are different conditions that can present with the medial scapular pain as described by Ben Kibler himself. So the most important take home from this slide is that instability patients may not have pain at all. So just because they don't have pain doesn't mean that they don't have a lesion. So this is very important for you to take home. Try not to miss out on this. So the unusual thing should be done first. What you're likely to miss out is looking from the back towards the scapula and checking for Baton's criteria for ligament laxity. For a quick short case, you just need to look from behind and look at where is the location of wasting. Is it only infraspinatus? Is it supra and infraspinatus? Does it involve deltoid? And this is best assessed looking at him from behind. You will miss all this precious information from the front. A scapular winging, a high riding scapula, or a trapezius spasm is best appreciated from posteriorly. In a short case, when you want to do a quick examination and you know it's a young patient, he doesn't have stiffness, you can do a quick test like this. And this is composite examination of the range of movement. And if he can do these two things, you know that he has a full range of movement because this is a combination of extension, adduction, internal rotation, as opposed to flexion, forward flexion, abduction, and external rotation. Now, I want your attention for this one slide. This is something that the books don't give. And time again, I know it is difficult to focus for 40 minutes on a presentation, but we just jot down the range of movement as it is forward flexion, abduction in a very arbitrary manner. What I want you to do is in an incisive manner, look into it and analyze. There's a lot of information coming from there. So if a patient has a passive movement, which is more than active movement, then you must realize that he's probably got a rotator cuff tear or a neuropathy. If a patient has a painful arc between 50 to 120 degrees, then you know that he has a supraspinatus lesion. It could be a partial cuff tear, it could be a inflammation, supraspinatus tendinosis, or a calcification. But now let's go deeper down into this. A patient has a very reasonable forward flexion abduction, may not be normal, but say it is 130 degrees abduction and 140 degrees forward flexion. But his rotations, external rotation is 10 degrees, internal rotation is 0. So you have to imagine that the advantage of the shoulder joint is a ball and socket joint. And so the rotations are the sine qua non of a shoulder joint as a ball and socket. So when your rotations are affected, it means the ball and socket joint has stopped behaving like a ball and socket joint. It is now behaving like a hinge joint. So conditions that can create this situation are adhesive capsulitis, osteoarthritis, or a dislocation where the ball and socket joint is not in contact anymore. Let's flip this scenario upside down and check where the rotations are completely okay, but the forward flexion and abduction are suspect. And this condition will happen if there's an axillary neuropathy or a suprascapular neuropathy, or there's a severe impingement due to a large subacromial bursa, often seen in rheumatoid arthritis patients, or there's a massive big spur under the acromion. Now, looking at scapular movements, this top patient, he looks odd, but he's a normal guy. The movements of scapula look odd, but they are symmetrical and rhythmic. Whereas the patient below, the lady, has very stiff glenohumeral joint, and this is pure scapular compensation. So this is like zero movement at the glenohumeral joint, and this is pure scapular movement contribution. And that's a classic adhesive capsulitis bilateral. In this case, you will notice, sorry. So this is a facioscapular humeral dystrophy, and you can see that the deltoid and supraspinatus are strong, but because the scapula is not anchoring to the spine, he's just unable to go through. This highlights the importance and contribution of the scapula to the range of movement. So this is FSH dystrophy. Now, this is a young boy who got hit by a football on his accessory nerve. This is an acute accessory nerve palsy, complete gross swinging and lack of movement. But because there was no internal injury, there was no scar, it was just a blunt trauma. So we have treated him with a rehab program and allowed the neuropracture to recover. And this is his performance exactly 6 weeks after rehab. And you will see that he's able to go back and he's back to normal. So picking up this information from behind was most important. If you'd looked at him from behind, it would look like an impingement in a 13-year-old chap. This is clavicle fail, and you can see this is a very odd syndrome. And because the scapula is so fibrotic and there are scars and there is dysfunctional, he's just not able to perform his normal glenohumeral joint movement. So don't miss the pharyngeal deformity in these patients. Now, this is a lady who was okay till yesterday. Overnight, she's got up in the morning and she's just unable to lift her arm up. So this is like a pseudo paralysis, acute onset, and this is classic. It's probably the only condition that will occur overnight in the shoulder, and this is calcific tendinopathy of the supraspinatus, and you can't miss this. Unlikely you'll get this in a examination, but this is a spot diagnosis once you see the range of movement. The Hawkins test is very good to differentiate between cervical spine problems and shoulder problems, and it will be positive because of inflammation within the subacromial bursa. But do be careful, in some patients it is so acute that it can cause a lot of pain. So oftentimes I would do this at the end of my examination. So coming to common conditions only, we would like to cover some of these. In the young patient, instability, you all are very familiar with shoulder dislocation and the recurrent nature of these. What I want to draw your attention is that if there is a very large rotator cuff tear, they can present with recurrent dislocation if the subscapularis is involved. So if you have a full thickness subscap tear, they can come with repeated dislocations. Don't miss that in the elderly patient. Now, often the sulcus test can be performed by the examiner, but most patients will be able to do it on their own. And you can see this is a classic sulcus in both these patients. It's a sign of ligament laxity. It doesn't mean that they have a Bankart tear. For a Bankart tear with a recurrent dislocation, this is the Drawers test. You need to get the patient really comfortable. Your left hand should be on the anterior glenoid and posterior glenoid borders, and the right hand will be on the humerus, not on the biceps, because you don't want to create pain. And you can see in here, we are getting 2 stations anterior, 1 station posterior. So he's an MDI patient where he has instability in bidirectional manner. But you need to inspire a lot of faith in this patient because you need their cooperation. Otherwise, a little bit of guarding and you'll get a false negative on the Drawers test. But this here is the classic load and shift test. And you will see that we are able to dislocate this shoulder completely anteriorly. Again, I would prefer to do this under general anesthesia. I rarely do this in the clinical setting. So don't do this in the OPD because it can cause problems. In an exceptional patient, I would do the load and shift to prove an extreme instability. And look at this patient. I'm getting to relax and I'm able to dislocate his entire head of humerus, bring it out through the axilla. And you can see a clung there as it comes out and goes back in. This is, of course, an MDI patient. They're not so apprehensive. They don't have pain. Now, this is interesting. This is a patient who's studying in Australia and he's had left-sided injury or a capsular dislocation. So when you have a Hagel tear, which is a very rare condition, watch the gauges sign. On the right normal side, he has some ligament laxity. You go about 15 degrees above 90. Whereas if you're going to go 15 degrees opposite the normal side easily and causing pain, then that's gauges sign. So gauges sign is a sign of inferior capsular rupture. It's an extremely rare black swan event, but it must be picked up very easily because conventional MRIs will consistently fail to diagnose this. Your classic anterior dislocator will have an anterior apprehension test. During this test, the student must always look at the patient and not at the examiner and demonstrate that the patient is perturbed, he has anxiety on his face, because this is an apprehension test. But do be careful not to dislocate the patient. So do keep it in less amount of abduction, less amount of external rotation. The same is better elicited on the crank and Job's relocation test, which has two components, the crank component and the relocation. Here you see on the crank, he has apprehension. With my left hand, I'm pushing it down. He has complete relief, he says. Moment I take the hand off, he has anxiety again. So that's your crank and Job's relocation, which has two components to be tested. This here is, of course, a posterior apprehension test, and it's not such a good test. Its specificity and sensitivity are low. Sorry, its sensitivity is low, specificity is high, and you would do it in adduction, internal rotation, and push the shoulder behind, and then look at apprehension on the patient. But this is a much more better test. This is the jerk or the Yankees test for posterior instability, and patients would typically do it on their own when they move their arm in the 90-degree axis, front and back, and you can see the head of humerus jump over the glenoid and come back. This is a highly specific test and very sensitive test, jerk test for posterior instability. This is a likely test in your exam. This is an architect and he's had 8 years of neglected posterior dislocation on the left shoulder. As I said, his abduction and forward flexion look reasonably okay. It looks like a frozen shoulder till he comes and does his rotations, and you see that there's a windswept deformity where his full rotation on the right side and on the left it is minus 40 degrees. He cannot even come up to neutral. So there is but only one diagnosis for a fixed internal rotation deformity, and that is neglected posterior dislocation. Please do not miss this in the exam because you'll fail that exam. And unfortunately, in this day and age, even today, I must say that almost half the patients or more than that of posterior dislocation are missed in the first instance. So be very alert on this condition. There is an interesting test here. This is the Rowe and Zarin's test. Sorry, let me come back again. Rowe and Zarin's test. So here the patient is affected on the left side. He can do an easy supination on the right side and a very restricted supination on left side. Truly speaking, supination has nothing to do with the shoulder, but I believe if there's a posterior persistent dislocation, then he will not be able to do a complete supination. It's an interesting test that has been described by Rowe and Zarin. Coming to GERD as a concept, you must understand what is GERD, which is glenohumeral internal rotation deficit. The patients who have an excessive external rotation here, this is about 120 degrees external rotation, they lose out on their internal rotation here, and that's only 70 degrees. So there's a deficit of almost 40 degrees as opposed to 110 degrees of external rotation. When you see this in a throwing athlete who is involved in repetitive overhead sports, then that's a serious condition which is likely to cause internal impingement and lead to a slap tear. So this is an important test that you ought to know. Coming to biceps conditions, there are several tests for biceps. On the first picture on your left side, you will see this is the Abbott-Saunders test for subluxation of the long head of biceps in the groove. On the right top side, what you're seeing is a forced supination, which is a Yergason's test. And the last is the most important. The bottom slide on the right is the speech test, is the most reliable test for biceps conditions. Now, in all these three conditions, the examiner has his finger, opposite finger, on the biceps. So the pain should coordinate with this movement. So if the pain is in the long head of biceps groove, only then is it positive. If the pain is elsewhere behind the shoulder, it is not a true test, because you must understand every test has a false positive and you must understand to pick them up. This I'm sure you guys understand. This is a Popeye sign and it suggests a rupture of the biceps. But in the exam, the examiner expects you to say more specifically rupture of the long head of biceps. Coming to slap tears, this is to be understood. There is no good test for the slap tears. It's tear of the superior labrum anterior to posterior. The O'Brien's test is one of the better tests where you do a resisted testing in adduction, forward flexion at 90 degrees and with the thumbs down. But it's probably not a good test, but it's the only test we have to diagnose slap tears, really speaking. Coming to AC joint tenderness, you can look for direct tenderness. As I said in the history, patients are unable to sleep on the same side and also on the opposite side because we do a cross adduction on themselves. So you could do that on the patient instead of the patient on himself. But when you do that and you generate the pain, you must always make it your business to ask the patient, where is the pain? Only if the patient suggests with the finger, then it's a finger sign positive, and that's your positive cross-section test. If the patient says the pain is behind on the shoulder joint, it's a false positive, suggesting posterior capsular tightness or a suprascapular neuropathy. Primary AC joint arthritis will have only terminal restriction of forward flexion and internal rotation. All the other tests will be negative. Unfortunately, this is always associated with some amount of rotator cuff disease, and so you never get a pure AC joint picture. Sternoclavicular joint is extremely rare. On the right, the patient has a rheumatoid arthritis, inflammation of the right SC joint. On the left, he has infection from his central line, and that's osteomyelitis of the medial end of clavicle and arthritis of the sternoclavicular joint. You probably can get a
Not able to hear anything.
Yeah,
Audio.
I think some problem with Dr. Ashish.
Yeah.
Actually, connection must be unstable, some sort of.
Unstable, I think, or yeah, I think.
Oh my God.
Maybe we have to, I think I hope he knows.
No, I'll call him 1 minute.
Yeah.
झालं काय?
Dr. Rajesh, are you with us? Dr. Rajesh? Dr. Rahul? Dr. Rahul Khatta?
Yes.
Dr. Rahul, actually, there is some technical problem with Dr. Ashish Babhulkar's, this thing. He's rejoining. Any comments about
I'm
him?
right here.
Okay, you are there, sir. You can
Okay.
Yeah. 1,000 apologies. These technological glitches happen.
No problem, sir. No problem.
Okay. Can you see my presentation now?
Yeah, we can see you.
Yeah.
Yeah,
Okay.
yeah.
Sorry about that. So the point I was trying to make, let me reiterate, it is important that in the middle ages, beyond 50, if you have a recurrent dislocation or even the first time dislocation, these patients have degenerate cuff, so they may have a rotator cuff tear, which would be missed because your larger attention is focused on the instability part, and because of the pain, they may not be able to test properly. So do be careful on that point of view. So clinical signs are typical. They have extensive wasting, range of movement could be normal. Hawkins signs typically positive. When you're dealing with a young rotator cuff tear, especially in an athlete, you would be misled because their cuff is very strong, even though there's a cuff tear in them. So you have to have a high index of suspicion in these patients. So the test for supraspinatus tears. So the principle in cuff tears is not one test is important because it can be false and you can be misled. So it is important to have a couple of tests. It is utopian to believe that one test will diagnose every condition. So we have two tests for every muscle tear. So supraspinatus has a full can and an empty can test. The beer drinkers amongst you will quite likely understand the concept of full can and empty can easily. So this is I.G. Itoe who described this in 1992. Now listen carefully. If only full can is negative and empty can is positive, it doesn't mean a cuff tear. It probably suggests a weak cuff from inflammation, partial cuff tear, or a calcification. If you have both full can positive and empty can positive, then it's highly likely to be a full thickness rotator cuff tear. So these are resisted supraspinatus tests. For the infraspinatus, again, we have two tests. One is you do an external rotation against the body, but look at the examiner's hands. The opposite hand is always palpating the infraspinatus to confirm that you're recruiting the muscle that you're testing. And this is important. You must make a big thing about this and tell the examiner that I am actually feeling for the muscle for its recruitment to ensure that you're testing correctly. He'll be impressed. You get few brownie points for that. But the better test for infraspinatus is this, because it fairly eliminates teres minor and you do it against gravity. And so this is called as the Hornblower's test. There are 2-3 different ways of doing this, but for a PG examiner, you must use these 2 tests for infraspinatus as such. Coming to subscap, which was described by Gerbers initially, what you need to do is a lift off test, take the hand behind the back and push it beyond. And if you can keep it mid-air, then that subscap is intact. If it cannot be retained in mid-air, then that subscap is probably torn. And then we don't rely on only one of this tests. What we do usually is do another test for the subscap, which is called as the Napoleon test. I need to pause my, there we are, sorry. Okay, so this is the Napoleon test where you put your arms on the front of your tummy and keep the elbows in the plane of the body and press your belly in. If your affected side, right side is affected, your arm will drop down. In this case, the left side is drop down, elbows behind the body's equator. So that's your Napoleon's test. Now coming to the lag sign, you might not be aware of this, but number of the tests are not 100% sensitive and specific. But if you have a supple shoulder with a full passive range of movement and the patient has a lag like this, where the arm is dropping down in front, then this is an unequivocal sign that there's a massive supra-infra tear and the subscap tone is pulling the arm ahead of the equator. So if you have an external rotation lag sign, then it's a good sign of a massive cuff tear. It's a very reliable sign. The better test is, I'm just going to stop the sharing and come back again because some of the videos don't seem to be working. Give me a minute.
Thank you, Dr. Ashish.
Sorry, just a minute. Just a minute. I wanted to play this video for them.
Yeah, sure.
For some reason there's not being. I'll just rush through the rest of the presentation. There seems to be a RAM issue here with my presentation. Any questions on my presentation?
Yeah, we'll go to our panelists. Dr. Rajesh Goyal, are you with us? Dr. Rajesh? Meanwhile, you can set up your video. Dr. Rajesh, are you there with us? Dr. Rahul Khatta?
Yes.
Sir, any questions regarding to PGs with Dr. Ashish Babhulkar's presentation, sir?
No, Dr. Ashish has very well enumerated all the clinical examination of the shoulder joint, which is very important. So, in my mind right now, I think he has completely enumerated all the tests and the various parts of the examination of the shoulder joint.
Okay. Dr. Harshad? Dr. Harshad?
Yeah, excellent. Ashish, as usual, up to his level of fame.
Thank you. Thank you.
Okay.
Thank you. Okay.
Yeah, you
Let
can
me
start,
just quickly
Ashish.
start.
We'll
The
talk
videos
later.
seem to be working. So this is testing the pec major. You do a resisted adduction. And if you see this wrestler on the right side, his retraction of the pec major, it is never a complete rupture. It is a retraction of the sternoclavicular part of the pec major, which is typically gone. And you see a thinner axillary fold there. What a clever student should do is immediately ask the patient whether there's a history of drug intake of anabolic steroids. Invariably, 9 out of 10 of my patients have taken anabolic steroids. So that's a bonus that you can share with your examiner to impress him on a pec major tear. So be careful. Just the tail end of my examination. This is of course the neuropathies which are often missed, and you would be very carefully in exam not to miss this. This is, of course, serratus anterior weakness because of a long thoracic nerve injury. And you are familiar with the wall push test. Very rarely there's a neuroma in line with the long thoracic nerve. You must know the surface marking of the long thoracic nerve so that you can pick up the neuroma and demonstrate a tender point on the long thoracic nerve. Again, more bonus points coming in here. For the suprascapular nerve, there are 2 points of tether. One is anterior next to the transverse scapular notch, medial to the coracoid. And the second one is posteriorly here as the nerve gives the branch to the supraspinatus and moves behind the posterior labrum here at the spinoglenar notch. And they manifest in very 2 different scenarios. If you look at this patient, this is a spot diagnosis. There is no other condition in a young person that can cause isolated wasting of infraspinatus, as you can see here. So this is compression of the suprascapular nerve in the spinoglenar notch. So here, this is an accessory nerve neuropathy. You see a superomedial winging of the scapula, which is atypical as opposed to the entire medial border winging, and typically seen in accessory nerve injuries, which are always iatrogenic. There is no de novo compression of accessory nerve. All the accessory nerve injuries are iatrogenic. This is a lymph node biopsy. That's why I showed this picture here. So do not forget to look into the neck and ask history of long thoracic nerve or a neck surgery such as a commando procedure or similar. But the better test for trapezius weakness on this left side is normal. On the right side, he's had lymph node biopsy and he's just unable to lift his right upper limb up in the prone position. This is called the triangle sign. This is a far superior test, and your examiner will leave impressed and forgive all your other lapses in the exam if you can demonstrate a triangle sign for accessory nerve palsy, published by Offer Levy in 2009. If the patient has trapezius tightness, on the right side, you can see that the neck has incomplete rotation. But if the examiner lifts the left arm up and relaxes the trapezius, he immediately have improvement in his rotation of his neck. And that's called as a Manskay's test for trapezius tightness as such. Finally, this is a corkscrew test where a patient has MDI. He's able to subluxate and dislocate his shoulder voluntarily. But moment you recruit his core and ask him to stand on one leg and squat down, he's not able to do that. That's because he's recruiting his axial muscles, stabilizing his scapula. But these patients do have a very poor core. So you work on their core and they are able to stop the recurrent dislocation. So these are few of the gems that you can demonstrate to the examiner, because you can get an MDI patient, especially a young patient like this. So in conclusion, you must also ensure you've not missed thoracic outlet and that you've not missed cervical spine as you would normally do a joint above and joint below. And with that, I think I'll conclude my shoulder examination. What I want to reaffirm here is that I'm fairly imaging agnostic. I rely a lot on history and examination. You must have unambiguous tests. You cannot rely on one test. That's a very utopian thought that one test will demonstrate supraspinous weakness. So you must have composite testing and decide that this is actually the diagnosis, like a O'Brien's test, like a GERD, like a throwing injury would demonstrate a slap tear, not only one aspect of O'Brien positive diagnosis, a slap injury. Thank you very much for your attention.